Hello, this is Megan Staffinson, and welcome to my presentation on Patricia Benner's model of skill acquisition in nursing, more commonly referred to as From Novice to Expert, based on her similarly titled book in which her theory was presented. I hope that this theory encourages you as much as it did me, reminding me that our nursing careers and educations are a process, and that our knowledge will increase as we engage in actual practice. As our book relates in Chapter 22, Patricia Benner was born in 1942 in Hampton, Virginia. She was the middle child in a family of 3 girls. Her family moved to California when she was a child, and her parents divorced before she graduated from high school. After graduation, she became interested in nursing while working as a clerk at a local hospital. She graduated from Pasadena City College with an associate's degree in nursing, while simultaneously graduating from Pasadena College with a bachelor's degree, both in 1964. She received her master's from the University of California, San Francisco in 1970, and her doctorate from the University of California, Berkeley in 1982. She has been a faculty member, in one role or another, at the University of California, San Francisco since 1982, and is currently a professor emerita. She's an author of more than 12 books and has served as the director of the Carnegie Foundation's Preparation for the Profession program, focusing on nursing schools and the education of future nurses. I found it particularly interesting that Patricia Benner is one of the few nursing theorists to marry. She married Richard Benner in 1967 and remained married until his death in 2016. The couple had 2 children, which were born between or during her master's and doctoral programs. Theoretical influences of the model of skills acquisition in nursing. Patricia Benner describes being influenced within the profession of nursing by Virginia Henderson, who is known for her nursing philosophy, which helped define nursing. Her view of the person was influenced by several existential philosophers, Martin Heidegger, Soren Kierkegaard, and Maurice Merleau-Ponty. But her greatest influence was the philosopher Hubert Dreyfus and his engineer brother Stuart Dreyfus. These men were her contemporaries. Together, the brothers created the theory of skill acquisition, which Benner adapted for nursing practice. Using their stages of skill acquisition, she was then able to describe the process by which nurses learn to practice, and how we learn and develop what she calls skills of involvement through experience. Theoretical assumptions. The theoretical assumptions for Patricia Benner are not actually listed in our book as they are for most of the other theorists. The list I found is not necessarily directly from Patricia Benner herself or her theory, but gathered from within her writings by another author. I will highlight the 2 that represent the theory the most clearly, the first and the last. Theory is derived from practice. Our book discusses the difference between knowing that, or theoretical knowledge, and knowing how, practical knowledge. Benner believes that the clinical practice is the richest source for knowledge development, and that while theory is derived from practice, practice can extend a theory, meaning that theory is created based on practice, such as clinical observations, questioning protocols, things like that. But the use of the theory in our daily practice can make our practice better. No practitioner can practice beyond experience. The idea here is that no matter what stage you're at, novice, proficient, or expert, you can perform at your best. You can be the most knowledgeable advanced beginner on the floor, but if you've never encountered a specific clinical situation, experiential learning is required. To move forward in skill acquisition, you must gain the necessary experience. Stages of clinical competence, skill acquisition. So this is a visual breakdown of the 5 stages: novice, advanced beginner, competent, proficient, and expert. These are the same 5 stages developed by the Dreyfus brothers, but now, thanks to Patricia Benner, they relate to nursing practice. So let's look at each level individually. Stage 1, novice. A novice is a beginner, usually a student nurse. They have zero experience and are given very strict rules to guide them through tasks and are not patient specific. Basically, they're told what to do and they simply follow instructions. Stage 2, advanced beginner. These are usually what we would consider new grads. Benner describes them as possessing the knowledge, skills, and understanding, but lacking in the in-depth encounters in population. These nurses are starting to be able to piece together their knowledge with the experience that they've encountered and may be able to begin settling their own guidelines for their actions based on these experiences. Stage 3, competent. Well, that sounds like an improvement, right? Competent nurse. And it takes approximately 2 to 3 years to reach this stage. These nurses can plan and organize effectively and are beginning to see the big picture in patient care, but they still lack efficiency and adaptability that is found in higher stage nurses. They're able to recognize patterns and interpret clinical situations more quickly and accurately. For example, they would be able to recognize a patient with hypoglycemia based on an awareness of the patient's history, a knowledge of symptoms, and experiences that when they've cared for patients with this problem in the past. Being able to put those together allows for quicker interventions and better care. Stage 4, proficient. This usually takes about 3 to 4 years of practice. A proficient nurse has learned from experiences and is aware of expected outcomes and how to alter plans in response to events. They view situations more holistically and are able to detect more subtle nuances and intervene when necessary. In the example of the hypoglycemic patient before, this nurse would be aware of and watching for the hypoglycemia in advance. And they may even change treatment plans, adding a finger stick between meals or before bed based on clinical experience. Stage 5, expert. The expert does not rely on set rules, but has a deeper background of experience and an intuitive grasp of clinical situations. They are highly proficient. It generally takes 5 years to reach this level of clinical practice. However, some nurses will never reach this level in their practice. Concepts. The model of skill acquisition was initially put forth in 1984, but was expanded in 1989 with the help of Dr. Judith Robel to include the concepts of caring, nursing, person, health, stress, coping, and situations. Caring was defined as being, quote, connected and having things matter, with fused thoughts, feelings, and action. This explains what is important to an individual, which impacts what is stressful and how they may cope. Caring behaviors from the nurse include empathy, support, compassion, protection, and nurturance, which creates emotional investment and engages the patient. Benner states that caring is of primary importance because it creates an environment where the nurse is able to provide assistance to the client. Nursing. Patricia Benner views nursing as a caring relationship, a condition of connection and concern. Nurses have the responsibility of improving their skills as they progress, and the best way to do so is through experience. Person. As mentioned earlier in the presentation, she views the person from an existential perspective, believing in wholeness. And I quote, Dr. Benner and Robel characterize the person as someone who must deal with situations, body, personal concerns, and the temporary nature of events. Health. They did not redefine health. They used another group's definition, believing that health is not the absence of illness, and disease is not necessarily illness. Illness is defined as loss or dysfunction. They support treatments that make sense within the lived human experience. Situation. Dr. Benner uses situation instead of environment because of the social context. We interact and inhabit our world rather than just live in an environment. But if you read her writings, feel free to substitute the word environment for situation if needed. Stress. Dr. Benner and Rebel define stress as the disruption of meanings, understanding, and smooth functioning, so that harm, loss, or challenge is experienced, and sorrow, interpretation, or new skill acquisition is required. I'm going to say that again because I think it's actually a really good description of stress. It's the disruption of meanings, understanding, or smooth functioning, so that harm, loss, or challenge is experienced, and sorrow, interpretation, or new skill acquisition is required. I liked this definition, because it gives a range to our experiences with stress. Coping. This is simply what one does about the disruption caused by stress. I liked their definition here as well. Doing something directly or not doing something on purpose. Seven domains of nursing practice. Patricia Benner, in looking at the skills and competencies that she was encouraging nurses to acquire, found that she could basically break it down into 31 different competencies or skills. And then she went further and subdivided those into these 7 domains of nursing practice. Now, you won't find this in the book, but this was a part of her theory. So the 7 roles include the helping role, and just to go back, each of these 7 roles had multiple skills or competencies beneath them, adding up to those 31. So I'm just going to give you an example, 1 or 2 from each role, just to kind of give you an idea. So the helping role, for example, things like guiding patients through emotional and developmental changes, providing comfort measures, and preserving personhood in the face of pain or extreme breakdown. The teaching coaching function. Those are things like capturing the patient's readiness to learn, providing an interpretation of the patient's condition, and giving the rationale for procedures. So kind of explaining things to our patients, keeping them educated. Diagnostic and patient monitoring function. Those are things like detecting and documenting significant changes in a patient's condition, anticipating problems. Effective management of rapidly changing situations. Kind of a mouthful, but basically being skilled in performing life-threatening, or being skilled in life-threatening emergencies. Administration and monitoring of therapeutic interventions and regimens. These are things like starting and maintaining IVs and IV therapies, administering medications accurately and safely. Monitoring and ensuring the quality of healthcare practices. These are things like getting appropriate and timely responses from physicians, documentation, organizational and work role competencies. These are kind of bigger picture things like setting priorities, building and maintaining a therapeutic team. So these were her 7 domains, created to cover the different skills and competencies that she's encouraging nurses to acquire. So this is used mostly in facilities to kind of track where nurses are in the development of these skills. Practical application. This model is unique from the other theories we've studied so far in that it is used to assess nurses in their education and practice instead of showing them how to practice differently. It's used in practice, administration, and education. In practice, for acquiring competence and expertise, a nurse must gain knowledge through formal education combined with the experience from our everyday practice. This is why clinical competencies are being utilized in most hospitals and clinics to assess their employees' skills and knowledge. training, orientation, exposure to unit-specific schedules, and continuing education will all be done to ensure employees are competent. This theory enables hospitals and employers to track competencies to assess stages of clinical skill acquisition. By administrations. This theory has been used to create mentorship and preceptorship programs, is the basis for the development of career ladders, which serve as a guide for promotion and moving up within an organization. It has been utilized as a method for identifying those deserving of recognition or awards. Even the framework for the Magnet Hospital program, which I know you're all familiar with, was based on this theory, encouraging more knowledgeable staff and future leaders. This model has most commonly been used in education. It was instrumental in helping educators understand how students learn and advance in knowledge throughout the span of their careers. It has provided the needed structure for knowledge development and an understanding of how nurses learn to become excellent in practice. Use in APRN practice. In studying Patricia Benner's model of skill acquisition in nursing, I have been encouraged daily. Being reminded that skill acquisition and knowledge integration is a process has been beneficial. While this theory is based on the skill acquisition framework of registered nurses working at the bedside, it is still useful for us today. DeSandre, in 2014, stated that socializing a seasoned or expert RN to an advanced practice role is one of the biggest challenges in nursing education. She goes on to state that, I quote, dual membership, meaning being both a novice and expert, often creates role confusion and serves as a barrier to the development of a professional identity as an advanced practice nurse. However, recent research suggests that role confusion can be avoided through successful mentoring and support of graduate students by faculty and clinical preceptors. Recognizing that there is a learning curve, that experience is vital to our development is important to reflect on as we feel unsure, like the novices we are. Becoming a mentor or preceptor is another way in which we can continue to grow and learn as nurses. As we continue in practice, this model will remain relevant as we continue to gain experience and knowledge with the goal of becoming an expert in our chosen field. Questions for consideration. Can you think of other ways this model could be useful in clinical practice? Do you believe that adding the concepts of caring, coping, and stress to the theory in 1989 was beneficial? Where do you see yourself in this theory? As an RN and also as a soon-to-be APRN. And now in conclusion, I hope that you learned more about the process in which we learn and the patterns in which developing knowledge occurs. Dr. Patricia Benner developed a unique model that is simple to understand, useful in both education and practice, and is fundamental in the understanding of what an expert nurse really is. Recognizing the changes by which we improve our level of care should motivate us to actively seek opportunities for new and challenging experiences as we move toward the completion of this program. We may be novices, but we can strive for excellence within our current stage until we reach the next. Thank you very much.